Welcome. This is a presentation that is not a sales pitch about, hey, let's hear it, about Medicare basics. It is on. Is it not loud enough? Is this better? Okay. Tells you how much I use mics. This is a presentation about Medicare and changes to Medicare. It is a 2-hour presentation. There is time for you to ask questions during the presentation, but please don't make them very personal questions because there's no way to address those in a large group. The presenters are Brenna Galvin, who is an elder law attorney with Mazur Law. Brenna has done all kinds of research on Medicare and has presented to Minnesota elder law attorneys. And Rachel von Ruden, who is a social worker and a community outreach specialist with the Senior Linkage Line. So you have copies of their presentations. One looks like this, one looks like this. If you run out or you want more, the electronic copy of these is available on the Roseville AD webpage. You can pick up a flyer for this. It will tell you how to get to the home page, and then on the easel that's out in the hallway, it tells you how to navigate that page to the bottom to find these. The event is being taped today by cable TV. We expect that it will be posted again onto this webpage by Monday. So please don't send me an email tomorrow saying you can't find it. Give them a little bit of time. You're laughing, it happens. We have also, in the materials you picked up, there's a 2-page evaluation form. Please fill that out. It really makes an enormous difference when we are trying to determine what is a substantive presentation for you, what is a useful location and organization to get you the best and the most information. If we don't get that back, then you're just stuck with whatever comes out of my head or somebody else's head, and God help you. It could be anything. You know, it's kind of Monty Python comes to the library. Other things. Housekeeping. The bathrooms are straight through the door at the end of the hall. You can find them. Please feel free to use them as you need them. What else? Dunn Brothers has coffee. You know how that works. And I think that's it. So, with no further ado, Brenna, and Brenna and Rachel will repeat your questions after you have asked them, so expect that. There are seats scattered around. If you have seats near you, please occasionally raise your hand so somebody else can find a seat. Thank you all for coming. And this is presented by the Roseville Community Health Awareness Team in conjunction with the Roseville Alzheimer and Dementia Community Action Team, it's all mouthfuls, and the library and the city of Roseville. So if you think this is valuable, please drop a note to somebody on city council and or somebody at the library just saying, hey, I came to this, it was worth my time. Okay? Thank you. There you go.
Oh, hi. I haven't even begun. Wow, generous bunch. Okay. I'm Brenna Galvin, and I am the elder law attorney that's been put on deck to speak with you about changes to the Medicare program. How many of you are over 65? Show of hands. All right, you're in the right place. If you're under 65, do you have a loved one over 65 that you're worried about changes to their Medicare? Okay, a few more. All right, so I think that what I'd like to start by doing today is making sure that you understand exactly what is included in traditional Medicare, as well as supplemental policies and Medicare Advantage policies, So you have that information and data to really evaluate your options. I know that health insurance in general is confusing, and it is made more confusing by the fact that we tend to not get a lot of information about what the core components of it include. So I really want you to be able to have that today, and with that data, you can make an educated choice either way. As Sarah said, neither Rachel nor I are salespeople. We are here just to try and give you the facts and the information you need to navigate these waters. And if you have questions about specific policies that may be out there, or kind of doing a side-by-side profile, that's not really my role today, and it will not be Rachel's as well. That could be done with a Medicare insurance specialist, and we can go over a little bit of those resources as well. So just to kind of go over again what our themes are for the day, is that I would like you to leave today with kind of a handle on what the ABCDs of Medicare really include, be able to identify the changes that are impacting your coverage and the why behind those changes, and give you valuable resources to help you evaluate those options. If ever there's a time that I move too far away or you can't hear me, just give me a thumbs up and I will adjust my volume accordingly, okay? So just to give you a little handle on the background of Medicare, Medicare was created in 1965. Now, it was created as a traditional health insurance program that would really be designed to provide you acute health care coverage. So if you had a broken arm, you could go to the doctor and receive health coverage to repair your broken arm. It really was not designed for preventative health care services, but that has expanded as the years have progressed. And we've gotten a better handle on the fact that if you want to avoid acute health care crises, we need to do some prevention as well, okay? So one thing that I'm always astounded by are the number of people that are currently covered by Medicare and becoming Medicare eligible. So approximately every 8 seconds in the United States, another person becomes Medicare eligible, okay? That's about 10,000 people per day and 4 million per year, okay? So Medicare is a huge health care, has a huge scope of coverage. Now, the Center for Medicare and Medicaid Services, that CMS, you might hear about them in the news. CMS is the entity or organization that administers Medicare and Medicaid programs in the United States. And they reported that there's over 59 million participants in 2018, okay? As the boomers continue to age and we continue to get older, we're going to keep seeing that number increase, all right? So what does this mean for people? When do people really become eligible for Medicare? Well, a lot of you raised your hands that you're over 65 or older, so that means that you passed. You're in. You are eligible for Medicare, okay? You can also become eligible for Medicare if you have a disability. And in order to be determined disabled for purposes of receiving Medicare, you need to have received Social Security disability benefits for 24 months. Now, there are some exceptions to that rule. One of those exceptions is if you have end-stage renal disease or kidney failure, or if you've been diagnosed with ALS or Lou Gehrig's disease. Now, those individuals can receive Medicare before that 24-month wait. And some of you might say, why? Why are those disabilities kind of treated differently than others? It really comes down to who lobbies and who has power in lobbying entities within Congress, okay? So a lot of this has to do with what happens, in our government and what happens politically. So You can also receive Medicare if you are a non-citizen, permanent resident over the age of 65, but you do have to buy in if you don't have enough work history within the United States, okay? So I want to talk a little bit about enrollment. Now, some of you are already enrolled, so this might be a refresher for you, but there are others who might need to enroll shortly, so I want to just cover this briefly. Now, the Social Security Administration, another federal entity, typically handles enrollment. And the reason behind that is the Social Security retirement age used to correspond exactly with the Medicare eligibility age as well, age 65. Now we see the Social Security retirement, full retirement age creeping up each year, and that's to help keep the Social Security program solvent. All right, so with that, we have the Social Security Administration largely handling people getting enrolled into the Medicare system, but the Centers for Medicare and Medicaid Services administering the benefits. Leave it to the government to make it complicated, right? We've got two different entities at play, but eligible beneficiaries, so if you're age 65 or older, who are receiving Social Security benefits will get automatically enrolled into Medicare Part A and B. Now, because so many people are not retiring at age 65, due to that increase in full retirement age or the fact that we're just living longer and better and want to stay engaged in our careers, you know, we are seeing a rise of people needing to actively enroll because they were not receiving Social Security benefits. So if you need to actively enroll, you can do so, again, with the Social Security Administration. Now, do we have any people in today's audience who are age 65 or older and still working? Anyone? A couple? Okay, I'm going to go over this real quickly then so you have this data. But if you're age 65 or older and working, you need to go through an analysis as to whether you need to actively enroll into Medicare, okay? So first we ask, are you covered currently by an employer group health plan? Yes or no? If yes, then is that group health plan based on your or your spouse's active employment? Are you actively working and receiving that benefit or that health insurance? If so, then we need to see if you have over 20 employees that are covered by that health plan, then you do not need to actively enroll. Medicare can be secondary and you can enroll later without any penalty. But if you're under 20 employees with coverage, then Medicare will be your primary and you do need to actively enroll, okay? So the act of retirement itself does change the need to whether or not you activate your Medicare enrollment. And it also changes the analysis. For example, if you're a retiree and you went from working, but now even your employer might still offer some retiree benefit. If you're over age 65, you still need to actively then enroll into Medicare, and that retiree coverage will be secondary. Okay? So when do you initially enroll? We're talking about who administers enrollment, but what is the timing to enroll? So the 3 months before you are eligible, the month of your 65th birthday, or the 3 months after your the month of your 65th birthday, you can go through initial enrollment. Now, the general enrollment period is for people who have kind of failed to enroll during their active enrollment period or initial enrollment period, and that's the first 3 months of each calendar year. But you should know that that enrollment's not effective then until the following July 1st. So there could be a big gap in coverage. So you do want to be sure that you're actively enrolling in the times you should. What we find ourselves, I went through some analysis for individuals who are working and need to enroll, and there is information in your materials about when that special enrollment period falls. But I want to spend a little bit more time today on the what we call as open enrollment, what we're in right now. That's really the term of art for it is the annual coordinated election period. Say that 5 times fast, right? So during open enrollment, that runs every year from October 15th through December 7th. All right, that is your time to look at what benefits you're currently receiving and make decisions about what you want for changes to that benefit. Or even if you don't want changes, and we're in this year where they're forcing you to make changes, this is your time to take care of that. So this is the time period most people either change from traditional Medicare or Medicare supplement to an Advantage plan or vice versa, or they enroll into prescription drug plans. What happens if you fail to enroll? I think that this is a big issue that people sometimes oversee. If you do not enroll, there can be costs, not just monetary costs that's ongoing, but also costs to the fact that you might not be able to get the coverage you need or seek the services you need for your health and well-being. Okay, so it's important that we follow up during the proper enrollment times. So let's go through a little bit over the parts of Medicare and the many, many acronyms related to Medicare coverage. So there are 4 parts to Medicare. Parts A and B are known as traditional Medicare. Okay, it's also called original Medicare, core Medicare, fee-for-service Medicare. Parts A and B were kind of what the original, what Congress initially had in mind as far as what would or would not be covered, and so is often referred to as original or traditional Medicare. Over time, we started seeing Medicare Part C emerge, and Part C is private Medicare. It's also known as Medicare Advantage, or MA. Okay, I want to lay all this out because we'll probably use some of these terms interchangeably throughout the presentations, and you might see some of these terms in the materials that you're trying to navigate. Okay, Part D is prescription drug coverage. All right, now what does each part contain? What does it mean to have Part A and B? Let's start with Part A and B, or traditional Medicare. Part A was a required component of Medicare, and this is really hospital insurance. It's free for individuals age 65 or older with approximately 10 years of work history. Now, if you don't have that much work history on your record, you might still be eligible, but you might have a premium associated with your coverage. Medicare Part B is supplemental medical insurance. This is confusing too, all right? Because sometimes we refer to Medicare and a Medicare supplement. A Medicare supplement is something else. It's something different. Part B is a core component that contains physician services, outpatient care, or preventative health care. And the standard premium in 2018 was $134. A lot of people might not realize that that's being charged. It's coming directly out of their Social Security benefit. So actually each month when the Social Security Administration deposits your monthly benefit into your checking account, that's the net amount after they've taken any sort of Medicare premium off the top. So the standard of premium applies to individuals who have incomes below $85,000 per year. We will go over a little bit more about how that premium changes or increases slightly as income increases as well. So let's get into the weeds a little bit, if we're not already, into Part A coverage. So Part A covers inpatient care in a hospital. It also can cover skilled nursing facility care if you meet certain criteria. It can also cover inpatient care in a skilled nursing facility that's not custodial or long-term. It's more rehabilitative. It can cover hospice and home health. Okay? So hospital insurance or Part A coverage includes hospitalizations that have 24-hour availability of a physician, and you need it immediately. There's no waiting days for that hospitalization. The coverage for hospitalization is limited by length and a cost-sharing liability. So a lot of people think, have in their mind that Medicare is a free program for all, or kind of health insurance for all. That's not the case, right? We contribute towards Medicare by having cost-sharing obligations or premiums associated with it. So there is a maximum number of days that they will cover in a benefit period, and there is a cost for day one, or the day you enter hospitalization. That's kind of ground zero. That's $1,340 for that initial day. And then the subsequent day 1 through 60 would be no cost-sharing obligation. Days 61 through 90 over, okay? Now, a lot of people might be saying, yeah, I was hospitalized though, and I didn't have to pay that. Well, that's probably because you're covered either through a supplemental plan, like a Medigap or a Medicare supplemental policy, or a Medicare Advantage plan that's trying to alleviate some of those traditional cost-sharing obligations, all right? So what does skilled nursing facility coverage include? So skilled nursing facility coverage does require a 3-day inpatient hospitalization or stay. And this is counted by 3 overnights. And this is where people often get tripped up, or I get calls from my clients or their children who are anxious about potential costs associated with skilled nursing care. They say, my parent fell and they were in the hospital, they were getting treated by doctors, they were there for multiple days in a row, and then they went into a skilled nursing facility based on what the doctor said was best for them, and they're saying Medicare's not going to cover that. The why behind what happens if Medicare's not covering that is because the person didn't have a qualifying hospital stay. The qualifying hospital stay is a big issue and is something that you need to know about in the event you're hospitalized or your loved one's hospitalized, because this is could have a huge cost to you out of pocket if you don't know about these kind of requirements. So there is no copays if you do have a qualifying hospital stay for the first 21 days or 20 days, and then day 21 and beyond there is a cost sharing obligation. I can speak a little louder, no problem, thank you. I might hold it here. Does that sound better? Okay, good. So the coverage, yes, ma'am. She asked, are hospitals required to tell you if it's an inpatient or if you're on observation status? Now, we will get into that more in detail, but the answer is yes. Hospitals are required to provide you what's called a moon notice. A moon notice is a one-page document that says, FYI, this is what your status is. Now, there is not really a requirement that this happen rapidly, okay? And there's not really a individual's right to appeal that notice. So if you find out that you've been hospitalized, but you're not categorized as inpatient, rather you've been on observation status, the things you can do are talk with your provider and say, I've needed this care. Can you please change my status, in essence, from observation to inpatient, and see if you can negotiate or wiggle there. Okay, we'll go into more detail about that shortly. Yes, ma'am. She inquired, are physicians able to backdate the admit date? They are not able to backdate the admit date without facing potential audit by Medicare or audit by the hospital administration itself. Now, the physicians aren't really responsible typically for how you're coded. That's the administration, but the physicians can advocate for a code change. Okay? So I want to keep going and talk a little bit more about a benefit period and how that works, because I did tell you that this coverage is limited to these benefit periods. So how do you calculate that? Not intuitively is the answer, right? Go figure. So a benefit period begins on the first day a beneficiary is admitted to the hospital and does not end until the beneficiary has not received a hospitalization or skilled nursing facility level of care for 60 days. How does this work in practice? I think I do better with examples. How about you? Yeah? Okay. So a Medicare recipient is hospitalized for 3 weeks. Okay. They had a major health crisis, had to enter hospitalization, and was getting their care within the hospital for a 3-week period. Think about a catastrophic stroke, for example. So during that 3-week stay, they're in the hospital, and after the 21-day mark, they are discharged to a transitional care unit or skilled nursing facility. They receive care there that includes therapy and skilled nursing care for 7 days per week for another 3 weeks or 21 days. They're then discharged home. If that Medicare recipient gets re-hospitalized in less than 60 days, the benefit period continues. This means that they start at already a period of days that have already the clock has already begun running, and then they pick it up right there and have a cost-sharing obligation. Now, this shows a little bit about what those cost-sharing obligations looked like in 2018 for that sort of hospital insurance. This is why these cost-sharing obligations are why people elect to have a Medicare Advantage plan or a supplement to help defer those cost-sharing obligations. So Part A, I also said it covers home health care, and there's some common misperception that Medicare doesn't cover home health care, and that is not true. Medicare does cover home health, and it's not limited in duration. So that means that you could really provide or receive a benefit if you need some help with services at home through the Medicare program, as long as you know kind of how to navigate or request those services. So the services, in order to get them, they must be ordered by a doctor or a physician, and the beneficiary, the Medicare recipient, must be considered homebound. And homebound doesn't mean that they can't have any fun or can't ever leave their house, okay? Homebound means that you need some assistance to leave. It's hard for you to leave home without the assistance of a cane, a walker, a wheelchair, or the assistance of another person. And there are some absences that aren't counted against people. For example, if they go to an adult day program or medical appointments, religious services. So there must be, in order to receive this skilled care coverage, there must be a need for skilled care within the home. And it does not generally provide or necessarily provide every single day, 7 days per week coverage, but it can cover up to 28 to 35 hours per week, which could be a big relief to people who are caregivers. Cock-a-doodle-doo. So there is some dependent coverage included that's not limited in duration, and there's no copays for this. So imagine somebody could receive some care at home that's covered by Medicare, and it's not subject to a copay. This can really help you. There's also hospice coverage, and in order to get hospice coverage under Medicare Part A, you have to have been determined by a physician that you have 6 months or less to live. And there's no skilled care or homebound requirement for this hospice coverage. Now, some people talk about, well, how does anyone really know how long we have to live? Could I receive hospice and live beyond the 6 months? The answer is yes. You can continue to receive hospice. They will just reevaluate your need, and then your services can continue without interruption. The services have to be considered reasonable, medically reasonable, and necessary, and that's going to be a theme from all Medicare coverage, okay? This is kind of part of the law that was originally enacted. They said that individuals' care that's covered must be deemed medically reasonable and necessary, okay? So the services have to be to help alleviate the underlying pain or kind of help provide comfort to the individual in need of hospice. And it's palliative in nature rather than curative. So some people say, oh, I don't want hospice. I've been diagnosed with cancer. I don't necessarily want hospice coverage because I heard I couldn't get treated for other things that might pop up. Well, if you get the flu and you're on hospice because you've been covered by because you've been diagnosed with cancer, you can still get treated for the flu when you're on hospice, okay? It's just the underlying diagnosis that you would not receive or elect to receive treatment for. And at any time, you can say, I want to get out of this program or back in. Now, some people say, well, I've noticed there is some expense to hospice care. My Medicare hasn't covered it for a loved one that I know, and that might be because if someone elects to receive hospice care in an inpatient facility like a skilled nursing facility or assisted living, Medicare doesn't cover room and board expenses. So sometimes those are privately paid by the individual beneficiary. Okay, so let's get to Part B. Let's keep it moving, right? Get to the good stuff. So what does Part B coverage include? Again, that's physician services when you go to see your doc, when you have outpatient care at a clinic, lab tests, for example, x-rays, medical supplies, durable medical equipment, and ambulance services are all under the Part B coverage within Medicare. It also includes some preventative care like a welcome to Medicare exam and a free annual wellness visit. Now, I want to differentiate everywhere it does say a wellness visit does not equate to an annual physical. Now, as somebody who's seen what a wellness visit contains and what a physical contains, it's hard to tell, when you're the patient going through this exam. So I would say it is important, though, for you to remember if you're trying to tap into that free doctor's visit covered by Medicare annually, you should ask for a wellness visit rather than a physical when you're calling to make the appointment, to be sure it's coded properly and that you don't have any cost-sharing obligations for that coverage. Now, Medicare doesn't provide hearing aids. This is what a lot of people struggle with because that is considered an out-of-pocket expense. Hearing aids might be covered, though, under another plan, like an Advantage plan or so that's something to keep in mind. Now, what are the costs of the Part B coverage? I've got some up, and as I told you, depending on an individual's income, they might have a greater cost-sharing obligation. Now, why are the amounts going up slightly every year? Why do we pay a little bit more for seemingly the same coverage? Well, we found that, of course, medical services the price of those services continue to rise. So Medicare has asked participants, in essence, or mandated that they increase their cost sharing to help cover those costs. Most people, though, do not just have Part A and B or traditional and original Medicare. They have some other type of coverage that helps them support them with their Medicare. And that could be employer coverage. That's what you'll see in the blue. So about 1/3 of Medicare recipients also have some sort of group health plan through an employer that's helping cover some of the extras or help alleviate some of the cost sharing. Another third in the green is the Medicare Advantage plan. Those are people who have opted in to get private Medicare coverage, and they're getting extras that aren't typically covered by traditional Medicare through an Advantage plan. The yellow color, or goldenrod, so that color is the Medigap or the Medicare supplemental policies that people might be on to help them with their traditional Medicare coverage. And the red, or the rust tone, is other coverage such as military coverage and Medicaid, or people who are duly eligible under the Medical Assistance Medicaid program and Medicare. Okay, so as you see, a lot of 2/3 of the people who are currently receiving Medicare today have opted to expand their coverage in one way or another through one of these other providers. So what is a Medigap policy? This we should have a little bit of an AKA, because that's also known as a Medicare supplemental insurance policy. Medicare supplemental policies are sold by private insurance companies, and their job or their role as a supplement is to help you pay for some of the healthcare costs that our original Medicare doesn't cover. So you are paying a little bit more as a premium on a monthly basis typically to help alleviate if you need a long-term hospitalization or skilled nursing care and there was a cost-sharing obligation for that care. That's when the supplement kicks in to help provide for that care. It also can help with co-pays and deductibles. So the purpose of the supplement is to say, we're going to pay a little bit more on a regular basis to ensure if we get sick and need this coverage, we don't have really high co-pays or deductibles. Okay? Now, let's kind of look at that in conjunction with what Part C or Medicare Advantage plans include. Part C coverage is administered exclusively by private plans. They're also known as health maintenance organizations, HMOs, or PPOs, preferred provider organizations. Now, Part C is all about the privatization of Medicare, right? So we see more and more insurance companies offering Part C or Medicare Advantage plans, right? So the Advantage plans that are on the market are private companies that have talked through and gotten approval with the Centers for Medicare and Medicaid Services, or CMS, has approved this insurance plan, and they're saying that they're going to offer you everything that Medicare offers you plus something else, okay? So it is somebody who you do not receive with Medicare Advantage plans, both traditional Medicare and these extras. You're opting into having your coverage exclusively managed by this private health insurance company, okay? So you are not in traditional Medicare Part A and Part B anymore. You are in Part C Medicare Advantage coverage. Okay, so what's the cost of Medicare Advantage plans? They have to have a structure that's considered actuarially equivalent to traditional Medicare. Most people say, what does that mean? And as a lawyer, it's a very easy answer to say it depends, right? So each Medicare Advantage plan can have different structures for how they handle cost sharing with their recipients, okay? So typically they need to say overall the cost to people is not going to be more than what traditional Medicare would offer. They have to be able to say that to the Centers for Medicare and Medicaid Services in order to get approval. So they can't charge you more, but they can average out to be about the same, okay? So some things might be more expensive, some things might be less expensive. There is a cap to an individual's out-of-pocket expenses of about $6,700 annually. Again, I want to reiterate that Part C is not supplemental insurance. They can't receive traditional Medicare and Medicare Advantage plans at the same time. You may switch or change coverage under a Medicare Advantage plan right now during the open enrollment period, but you can't receive, again, a Medigap or a supplemental policy at the same time you elect this Advantage because they're two completely different programs. One of the hallmarks of a Part C Medicare Advantage plan is that care is subject to pre-approval by the insurer, okay? So if you want to receive care or you think you need care, you would contact the insurer to ensure they approve it in advance, okay? Unless they approve it, it may not be covered. So the other hallmark of a Part C plan is a network of providers. What that means is that you have a certain group that you can receive coverage within. And if you say, no, I actually want to receive care from that doc, a few miles away, the Advantage plan might not cover it unless that doctor is within their network, okay? Now, if we contrast that with original Medicare and a Medicare supplement, almost all doctors do take traditional Medicare, okay? So you do have a little bit more range with a traditional Medicare and a Medicare supplement than maybe a Part C Advantage plan. Again, Medicare Advantage plans have to cover the same thing that traditional Medicare does. But that's a floor and not a ceiling. So people tend to look at Advantage plans and say, wow, the really nice thing about this Advantage plan is that it's one-stop shopping, right? It's easier to navigate the shopping or looking for the coverage because that they have components of Part A and Part B coverage and maybe even some prescription drug coverage as well as maybe some things like some of them cover some hearing aid costs, some of them cover some dental work, some of them cover gym memberships or wellness plans. So typically Part C looks to be more advantageous for consumers in some ways because it contains one-stop shopping for them. However, there are some cons to Medicare Advantage plans that I want you to be aware of, and from what I see, and again, I'm not somebody who sells insurance, but the cons include that it is sometimes worse for people who actually need to use a lot of health care, so people who are chronically ill or have a diagnosed disability or who are sicker and are trying to utilize this benefit, they could face loss of coverage or increases to their price structures. And once you've elected to go with a Medicare Advantage plan, it's hard for you to then opt out of an Advantage plan and back into traditional Medicare with a supplement. Hold on, 1 second, I'll finish this thought and come to a couple of questions or hands that I saw. Now you might say, why? We have open enrollment or this annual election period every year, so why is it hard for us to change from a Medicare Advantage plan back to traditional Medicare and a supplemental policy if we want to? The answer is that you can only opt or go back into a supplemental policy if you fall within a guaranteed issue period. Otherwise, you might be subject to a health screening before they will issue you a supplemental policy. So if you're chronically ill and sick and you're not liking what you're getting on Medicare Advantage and you want to switch to a supplement with traditional Medicare, you may only be able to do so if you kind of pass their health screening, and they can screen you out based on pre-existing conditions. Now, there are certain times that you're not subject to that, and that's called a guaranteed issue period, and we'll cover that really shortly. Now, there were a couple of questions that I'll quick address.
Just have a quick question. So, I'm paying for A and B, I assume, deducted from my Social Security, but I'm also paying a monthly fee to Health Partners. So, and every once
So she was giving an example about how when she pays kind of her premium off the top, maybe for traditional Medicare Part A and B from her Social Security, plus she contributes monthly to Health Partners plan. That could be a cost plan that we're about to go through now, so that works a little differently than what we've gone over already. But with a cost plan, they are tapping into traditional Medicare as well as, so that would be Part A and B, and also offering Part D coverage or prescription drug coverage. I'm going to talk about cost plans so you can say, well, what are these supplemental policies and what are these advantage plans compared to what I currently have? Because how many of you people that are in attendance today have a cost plan? The majority, right? So a lot of you are here because you've been told your plan is terminating, right? Okay? You're like, I don't, just get to what we have and why we need to be worried, right? So Medicare cost plans are really hybrid policies, okay? So if it wasn't confusing enough, Medicare plans that are cost plans share features from Medicare Advantage and a supplement. So it was kind of thought to be the best of both worlds. That was until the law changed, okay? And those cost plans are being phased out. So what it offered was the flexibility of traditional Medicare coverage. So a lot of people could access out-of-network providers as well as receive their coverage in-network as well. The reason that these policies came into existence was that it served areas of the country that traditionally had very few Medicare Advantage plan offerings. Well, that's changed, okay? So in 2003, Congress created really a competition requirement, and that was also, thank you for the thumbs up. So in 2003, they made this competition requirement, and that was refreshed again in 2015. And at that time, the Center for Medicare and Medicaid Services said, we're not going to renew Medicare cost plans in counties where there are at least 2 or more Medicare Advantage plans with a base or a certain number of members in it. Okay, so the plans can't be offered in service areas where people could get a comparable Medicare Advantage plan. Now, the implementation, even though these laws were passed long ago, that implementation was held off until 2019. This has the largest impact of Minnesotans than on anywhere else in the country. Okay, so I want you to look at these numbers. There are 630,587 people who are enrolled in Medicare cost plans. And guess how many of those are in Minnesota? Almost 400,000, right? And really, nationwide, there's about 20 million people covered by Medicare Advantage plans. So the cost plans just made up a small fraction of that. And the majority of those recipients were right here in Minnesota. So the metro area was the area that was most impacted because there were many options on the market, or are many options on the market now. I spoke before about these guaranteed issue rights, what options you have when your policy no longer exists and you have to make a change. When can you go ahead and make those switches and have the greatest number of options and get guaranteed coverage or issue? So guaranteed issue rights are also known as Medigap or Medicare Supplement protections. These are circumstances that you have when insurance companies are required by law to sell you a Medigap or Medicare supplemental policy, even if you have pre-existing conditions. Now, there is a large chart on Medicare.gov that goes through every iteration of when you have guaranteed issue, but the most commonly used examples are when your plan is leaving Medicare, right now, for many of you in these cost plans, your plan is leaving Medicare altogether. So you get guaranteed issue. That means you can switch to a supplemental policy without being shown or having to show that you have a certain level of health. Okay? You can also get guaranteed issue if you are making a change within 12 months of switching from a Medicare Advantage plan. Okay, so if you opt to go with a Medicare Advantage plan and you decide, this isn't right for me, you can have guaranteed issue as long as you make a change within 12 months. Okay, so that's important for all of you to keep in mind as you're evaluating, do I look at a Medicare Advantage plan? Do I look at a Medicare supplement? Of course, there's also other considerations like cost and budget, right? That's a huge consideration to what option is best for you. But I want you to keep in mind what are hidden costs as well as the costs that you might have for monthly premiums. Yes? Mm-hmm. 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 There is, I do not know of this. So what she said, just to repeat back, is that she was under the understanding that the guaranteed issue rights were being sunsetted, and that yes. So she was asking if it's right that the guaranteed issue periods are sunsetting. And to be honest, I don't know of that sunset, but it could be, I wouldn't be surprised by a sunset with guaranteed issue, because what we're seeing is right now with the current political climate, that people are preferring privatization of the Medicare program, right? So even we've seen a shift this year in the Medicare and You handbook that's issued by CMS annually that really is pushing people towards Medicare Advantage plans and away from traditional Medicare and Medigap or supplemental policies. This is, those differences can be subtle, but they are there compared to other years. And so I think it's important to keep in mind that if you are someone who's chronically ill or has a diagnosis, you might want to look or get yourself to a plan that you're guaranteed kind of some coverage within, rather than a plan that might not be sustainable in the long run. Okay? Yes, sir. Mm-hmm. So what he asked is, does the annual election period, is that extended for people who are losing their Medicare cost plan? And the answer is yes, and Rachel's going to talk more about that extension, okay? So what I want to talk about really quickly is Part D, or prescription drug coverage. Part D is the part of Medicare that provides outpatient prescription drug coverage to you. Part D is also administered exclusively by private insurers. It's a voluntary program. You don't have to enroll in Part D, but if you want it, you must affirmatively enroll. Again, you can do so right now during this open enrollment period. But if you decide not to have Part D or something that's comparable, you may face a penalty or increase in charges for Part D at a later date. So you don't need to enroll in it, but if you don't enroll, or you don't enroll into an Advantage plan that has Part D coverage as kind of a component of it, then you might face increased costs if you want to enroll in it at a later date. So what do those costs include? There's a monthly premium for Part D coverage, there's cost sharing for prescriptions, and those amounts are based on annual income, kind of like the Part B premiums were that I showed went up depending on how much somebody made annually. When we talked about Part D before, we talked a lot about the donut hole. Okay, so people would find themselves in the donut hole. And what that meant is a gap in coverage from when your drug costs reached a certain amount, and then the Part D wouldn't cover prescription costs for a period of time until you reached another amount, and then it would kick in again. So in 2019, the donut hole is going to be closed. Okay? So that will be a big help to people, and that was as part of the Affordable Care Act. Now, I wanted to show you a side-by-side, and it's a little hard to see in the materials. It's a little easier on this big screen about what the costs look like in 2018 and 2019 for Part D standard benefits. Okay? Now, I'm not going to leave this up because I know you have it in the materials you can take home. But I want to talk a little bit about issues that I'm seeing with my clients that might apply to you. And my clients are mostly age 65 or older, or caregivers for individuals that are age 65 or older. Okay, so what happens when they've been denied coverage? What is it like to go through a Medicare appeal? And the answer is, it stinks, right? It's not good to have to appeal anything in this life. So what people should know are there are expedited appeals for beneficiaries of Medicare. Now, what previously happened is that all appeals, be it a provider saying, hey, we think Medicare should have covered this, and the beneficiary also thinks Medicare should cover this, but we're not being paid. The provider, the health provider, also appealed within the same place that the beneficiary, the Medicare beneficiary, appealed. So you can tell that that appeal system would quickly get overwhelmed, which it is. You can get expedited appeals if you are a Medicare recipient, and you need to really mark your envelope as beneficiary appeal or expedited appeal. There is a 5-level review when you start going through, and it's been our experience and the experience of many elder law attorneys that the first 2 levels of appeal are rubber stamp denials. Okay, so people put in a list saying we disagree that we've been denied this coverage. They get back a statement from the agency that's reviewing it. They're saying, nope, you're denied. They appeal again. Nope, you're denied. When we hit the 3rd or 4th level is when we get people to listen. Now, for a lot of people, this isn't a system that's really great or sustainable for them, because imagine if you're wondering whether or not you have to pay this large hospital bill, or whether you need critical care and it's not being covered, the out-of-pocket expense associated with that. But I do want to tell you there is a really great consumer resource out there, and you'll see I've included in the back of the packet as well under resources, but you should familiarize yourself with the Center for Medicare Advocacy. The Center for Medicare Advocacy is a nonprofit national organization that exists to help consumers and Medicare recipients navigate their benefits and get the benefits they're entitled to. Okay? There's a appeals toolkit that they offer, so you don't have to go through an attorney and incur that cost if you are denied coverage you are entitled to. Okay, so that can be very helpful. Now, I want to talk a little bit about another issue that Medicare recipients are experiencing, and that is what happens if they are admitted from hospitalization. They've had a qualifying hospital stay, and then they are discharged into skilled nursing care, and that skilled nursing care is covered by Medicare up to a certain number of days. They're being told by the healthcare provider or the social worker at the facility in many cases, you or your loved one's no longer improving, so Medicare is not going to cover this care. Well, what you should know, and I'm seeing some nods, yeah, I've heard of that, right? Oh yeah, that happened to me or my loved one, right? Well, the reality is that is not what the rules say anywhere. However, there was a large, and there still is, we're still having to do a lot of advocacy around this area. The actual rules say that you just need that care to continue to maintain your health. It needs to be medically reasonable and necessary to maintain your health. Nowhere does it say you must improve in order to get coverage. So there's no expectation of improvement in the law. And this applies to skilled nursing facilities, home health, outpatient therapy, rehab. So it's widely being applied by these facilities, but we have had some relief, a little sliver of relief with this major class action lawsuit that took place on a federal level that actually was brought by the Center for Medicare Advocacy. It took this lawsuit and said, nowhere in the law does it show that people need to improve to get this coverage. And if you've had somebody in a rehabilitative facility, you understand that those daily rates can be about $350 per day. So this is a huge cost for care. So there is a corrective action plan. The Center for Medicare and Medicaid Services are trying to make sure that providers know about this. If this is something you hear in a care conference with your loved ones, you need to know about this and show them. You can bring my slide with you and show them that that's not indeed the law. And the other issue we started talking about earlier is what happens when you are in the hospital but on observation status. So care in a hospital is often indistinguishable for patients when they're inpatient or on observation. That's what makes it hard. You go into the hospital, you're in the gown, right? Your back's open to the public. You're sitting there getting care by a doctor around the clock, and you might even be on an IV, and you might be saying to yourself, how do I know if I'm on observation or inpatient at this point? Because it can look the same for you. Now, observation status, unfortunately, has been the status quo for a lot of hospitals and healthcare providers. Okay? So people wonder, why are they being designated as observation rather than inpatient? Do the hospitals have a financial motive? And the answer is it could be fear-based or financially motivated, but it's really not the way we think. They're not getting more money from an individual or private consumer than they are from Medicare for that daily rate. The issue they're concerned about is that they're going to fail at some point in audit by the Center for Medicare and Medicaid Services or one of their auditors to say, you've been doing this wrong and now we're not going to include you as a provider that's covered. Okay, so that fear of loss for them is more motivating than your individual cost. Now I think that's wrong, and you should too, because it greatly impacts my clients, okay? So if an individual is not inpatient, that means that you're denied your Part A coverage for the hospital stay. You're denied Part A coverage under a skilled nursing facility stay and prescription drug coverage while hospitalized. Now, what's important to know is that there's no way to appeal if you've been put on observation status. That's not an appealable right that we have. So there's things that you need to do to protect yourself if you're hospitalized. What are your rights? You are entitled to a MOON notice, Medicare Outpatient Observation Notice, within 36 hours of being hospitalized. You can ask for it sooner. Okay, but you must receive it within 36 hours. And you may argue with a hospital about the distinction or the status, but any changes that occur are not supposed to occur retroactively. Now, there's the law and there's what people do. It doesn't always match. So I don't know. Some people have told me that they've had a provider who has retroactively changed their status. That's not supposedly allowed but it could happen. I have had some luck with community physicians advocating to a hospital provider and saying, this should be an inpatient. I know this patient. This isn't a standard observation of them. They really need this care for their well-being. Sometimes you can employ a community physician as an ally as well. But I think the most important thing for you and your loved ones is to know you should ask what your status is. And if you're not inpatient, you should figure out why and whether that can be changed as soon as possible. Okay? So the final issue I want to go over with you is this home health benefit. And the home health benefit I told you was a right of yours under Medicare Part A if you're receiving traditional Medicare. Access to the home health benefit has historically been underutilized. And that's really often due to a lack of understanding by people who are Medicare recipients and providers, health providers, that this is covered by Medicare. So it's important to educate yourself that this is a covered benefit for you. And it could allow people, I think, to move away from a need for potential Medicaid or medical assistance eligibility in our state, because if they could tap into a covered benefit under Medicare, they won't have to impoverish themselves privately paying for that care and then seek public assistance to help pay for it. Okay, so I did include a little infographic for you to talk about what's required to qualify. You can look at that or use that as a resource in the future. And I want to leave you with a few resources, and one of the biggest resources to you is right here in this room, and she's about to talk to you shortly. Okay, so the Senior Linkage Line is the state of Minnesota's SHIP program that is really an insurance. They are able to really help you navigate your insurance options and Medicare options, okay? So she'll tell more about what that organization includes, but they have a website, they have resources for people, they have a toll-free line, so you can utilize them. The Medicare.gov site, be careful because some people go to Medicare.com. That is not the government website, and it is an insurer that's kind of masking themselves. Okay, so you want to go to Medicare.gov for accurate information about the Medicare program and the coverage. You also should familiarize yourself with the Center for Medicare Advocacy. I've talked about them enough already. And if you're really trying to evaluate your individual options, you can also look for Medicare insurance brokers to help you evaluate based on your needs. Okay, so I'm going to pass the mic over, and Rachel and I are going to do a switch. Yes, ma'am. Sure. So she asked, am I required to have a Medigap policy or a Medicare Advantage policy, or can I elect to have just traditional Medicare? And the answer is you can elect to have traditional Medicare. If you do elect that you want traditional Medicare, you should be aware of what the cost sharing obligations are and be sure you can cover those expenses. And again, keep in mind that Part D coverage, if you decide you want a prescription drug plan at a later date and you don't enroll, you might have increased premiums or cost sharing down the road. Yeah. Yes. So what she asked was, I spoke about the fact that you can have opt for traditional Medicare alone or with a Medigap or a Medicare supplemental policy, or elect right now to go into a Medicare Advantage plan. And I stated that it may be difficult if you do elect to go with a Medicare Advantage plan and decide you don't like it to get back in to a traditional Medicare with a Medicare supplement. You can go back from a Medicare Advantage plan to traditional Medicare, but the supplement doesn't have to be provided to you unless you fall without a health screening, unless you fall within a guaranteed issue period. And those are kind of elaborated on your plan. The supplement is the problem because it's a private insurer. Yep. Mm-hmm. Yes, and go ahead. Mm-hmm. So what was asked is, does the Affordable Care Act help with the guaranteed issue rights because of the pre-existing? The Affordable Care Act said you are entitled to health care coverage even if you have pre-existing conditions, and that does not help you in this regard. Okay, so if you go to an Advantage plan and then want to go to a supplemental Medicare policy, that supplemental policy can screen you based on pre-existing conditions unless you fall within a guaranteed issue period. And, Rachel's also going to cover that too. So I want to be sure that we let her start, and then we'll have time for questions as well at the end. But that'll just make sure that you get some of these big issues she's going to cover and drive home for you. Last question. She asked, how do you know if you're on a cost plan? Did you receive a notice saying your plan's no longer offered? Then you're likely on a cost plan. Okay, so if you got a notice saying you're no longer going to be covered, most of those notices are because people in Minnesota were on these cost plans. Okay, that's a good question. Oh, thank you, sir. So what, ma'am? So what he also said is that your membership card for Medicare will also say. All right, I'm going to pass the mic. Thank you.
Okay, so we have some, can you hear me? Can you hear me now? So we have a little bit of motion in the room. We are, in case you walked in late, we are going until 3 p.m. today. So hang in there with us. We appreciate your time and attention this afternoon. My name is Rachel Von Ruden. I'm a licensed social worker and outreach specialist with Metropolitan Area Agency on Aging on the Senior Linkage Line outreach team. Is anyone here familiar with Senior Linkage Line? Oh, wonderful. Lots of hands. So Senior Linkage Line is your state health insurance assistance program. So we receive specific federal funding to be the local go-to for objective information, answers, enrollment assistance, etc. with regards to Medicare. So we are an objective source of information and assistance regarding Medicare in Minnesota. We do help with other types of things, and I'll talk about more of what we do later on today. So I would invite you, if you grabbed a handout on your way in, to go ahead and pull out my handout so that you can follow along this afternoon. My topics for you today are what's new with Medicare. We are going to focus mostly on some changes with Medicare cost sharing and the Medicare cost plan sunset, what Senior Linkage Line is, and then, of course, resources for help. We have lots of resources for assistance. So first, some changes with cost sharing for 2019. So original Medicare, Part A, for most of us is premium free because we have the required amount of work history. The Part A deductible is going up $4 for next year, so it's going to be $1,364 per benefit period. We're also going to have co-payments after following day 60 in the hospital. For new enrollees in 2019, they can anticipate having a Part B premium of $135.50. Some of us may have been on Medicare for quite some time and might have a premium that is lower than that, particularly if we are using Medicare and we're also drawing Social Security retirement benefits. In those cases, we are protected by something called the hold harmless provision, which prevents our Medicare Part B premium from increasing more than our Social Security retirement benefit. So we should be receiving notification about what our unique premium might be for 2019. The Medicare Part B premium has gone up, deductible. The Part B deductible has gone up a touch as well for 2019. It's going to be $185 for the year. And we're still going to have the same 20% coinsurance for Part B services. So moving on to the Part D as in dog coverage and the coverage levels. The maximum Part D, the maximum deductible for a Part D plan in 2019 is going to be $415. That's the maximum that a deductible can be for a Part D plan. A lot of Part D plans have a deductible that is lower than that, or they may have no deductible, but the maximum that it can be is $415. Our initial coverage period after we meet our deductible, if we have one, for our initial coverage period, we are responsible for 25%, about 25% of our prescriptions, and our plan pays the other 75%, up until the total cost of the drugs reaches $3,820. Once the total, yes. A little further. Is it bouncing? Where's the right distance? There's another noise. Is this pretty good? So I'm going to try not to move for the next 30 minutes. If I fail in that task, please tell me because I want to make sure that you can hear the information. All right, so once we reach $3,820, then we are in the donut hole. And thanks to the Affordable Care Act, we do have some discounts while we are in the donut hole. For 2019, we're going to have a 75% discount on brand name prescriptions and a 63% discount on generic prescription drugs. So in actuality, we're going to be paying about 25% of brand name and 37% of generic. And once our true out-of-pocket cost, what we have paid in total, reaches $5,100 for the year, we reach catastrophic coverage. And once we have reached catastrophic coverage, we have very low costs for our prescriptions. We pay either 5% coinsurance or $3.40 or $8.50 per prescription, whichever number is greater. So a lot of people see these three coverage stages and it might give them quite a bit of anxiety because they think, oh boy, what's this donut hole? What am I going to do if I hit the donut hole? I didn't even know it was there before. And keep in mind, not all of us hit the donut hole every year. And some of us might hit the donut hole in June. Some of us might not hit the donut hole until December. So just because the three levels are there doesn't mean that all of us make our way through the three levels. And I'll mention Brenna already mentioned this resource. Medicare.gov has an excellent plan finder tool that can help us anticipate when we might hit the donut hole. All right, and this graphic is just another way of looking at the different coverage levels with Part D. So you see in the orange on the far left, we have to meet first 100% of our deductible if we have a deductible. After the deductible is reached, we are in the initial coverage level, which is that gray arrow, where we pay 25% of our prescriptions. Once the total cost of the prescriptions reaches $3,820, we are now in the donut hole where we are responsible for the total cost of our drugs, but we have discounts, which I mentioned earlier. And finally, once our true out-of-pocket cost reaches $5,100, or our prescription costs reach approximately $7,653, we are in the catastrophic coverage level. I think I hit the wrong button. Here we go. All right, so those are some changes to the cost sharing for Original Medicare for 2019. So now on to the Medicare cost plan sunset. We know a lot of you in this room currently have a cost plan, so you are in the right spot today. If you are unsure whether you have a cost plan, which some of us may be, there's a card up front here. It has a blue top. Boy, there's still quite a few up there, which is great. On the back of this card, it lists all of the Medicare cost plans that are currently sold in Minnesota. So you can use this card to double check whether or not you have a cost plan. Insurance companies in Minnesota that sell cost plans at this time are Blue Cross Blue Shield, Health Partners, and Medica. They also sell other types of insurance, but one of the types is a cost plan. So just be sure to check with your insurance company to determine whether or not you have a cost plan. If you have a cost plan and live in a county that is being impacted by this change, you should have received notification from your insurance company as well as from the Center for Medicare and Medicaid, CMS, in September or October. Right? Now, not all counties are being impacted by the cost plan change. So I had someone ask me a couple of weeks ago, why do you use the word sunset instead of just saying going away? That's because they're not going away in all counties. They're gradually going away. That's why we use the word sunset. It's a gradual process. So you see a map of Minnesota here on the screen. And the counties that are in dark blue are the counties where cost plans are going away this year. They're all ending December 31st of 2018. The counties in green are the counties that don't quite meet the competition requirements with Medicare Advantage plans. So legally, insurance companies can continue selling cost plans in those counties into 2019. Now, I had a gentleman at a presentation recently who lives in Dakota County, and he looked at this map and he said, well, I see that Rice County is green and they get to keep their cost plans. They can keep selling cost plans next year. And for those that aren't familiar with Dakota and Rice County, they're right next to each other. And he looked at me and said, well, can I just move to Rice County and keep my cost plan? And I said, well, I suppose you could, but before you make that big life transition, just keep in mind that the cost plans are sunsetting. So the end goal is for them to go away across the state of Minnesota. So we live in the 7-county metropolitan area. I'm imagining most of us do. So in the 7-county metropolitan area, our cost plans will be ending December 31st of 2018. So if I have a cost plan, what is happening? There is a process happening called deeming. And deeming is happening to some cost plan beneficiaries that have a cost plan that includes Part D coverage. Because with cost plans, we can choose to have our Part D included, or we could purchase Part D coverage separately in a standalone plan. So what deeming means is that my insurance company has worked very hard and has created a Medicare Advantage plan that is pretty close to the current coverage I have with my cost plan. And the Center for Medicare and Medicaid has given this new Medicare Advantage plan the stamp of approval. CMS says, yes, this Medicare Advantage plan is close enough to the beneficiary's previous cost plan, so they can be deemed. And deeming means that I will be auto-enrolled if I do nothing. I will be auto-enrolled from my cost plan that I have in 2018 to the comparable Medicare Advantage plan starting January 1st of 2019. Now, not everyone is being deemed. I will repeat that. Repeat what deeming means? The whole thing. Okay. I got the signal to repeat the whole thing. So, what deeming is only happening, it's only possible for people who have a cost plan that includes Part D. So they elected to enroll in a cost plan that includes Part D coverage. Because with cost plans, we can enroll in a cost plan that includes Part D, or we could have a cost plan and a standalone Part D plan. So we have two. So for those people that have a cost plan that includes Part D coverage, if their insurance company worked really hard and created a Medicare Advantage plan that is comparable to the cost plan that they currently have, and if the Center for Medicare and Medicaid evaluates that Medicare Advantage plan and gives it the stamp of approval that yes, this Medicare Advantage plan is close enough, it meets the $36 average increase per month requirement, then Medicare is allowing the insurance company to deem current cost plan enrollees into that Medicare Advantage plan. So what that means from a beneficiary standpoint is if I have a cost plan that includes Part D and I have been deemed, if I do nothing in 2018, I will be auto-enrolled into that Medicare Advantage plan starting January 1st of 2019. Now, I had one woman at another presentation who looked at me and said, well, I wasn't deemed. What did I do wrong? And it has nothing to do with us as a beneficiary. It has nothing to do with us or something we did or didn't do. It has everything to do with our insurance company, and it's our job to be aware of whether or not we've been deemed. If you're unsure, just place a call to your insurance company. That's the quickest way to figure it out. And then with that knowledge of whether or not we've been deemed, be aware of our choices and timelines. So we're going to talk about timelines next, and then I'm going to walk through the three different scenarios for people with cost plans. So just hang in there with me as we walk through this. So important dates. We have our annual Medicare enrollment period. We have this every year. It's an opportunity to enroll in a new Medicare Advantage plan, Part D, standalone plan, or a cost plan if we live in an unaffected county. Open enrollment is October 15th through December 7th of every year. October 15th through December 7th. In the 4 years I've worked with Senior Linkage Line, that's the only time I've ever messed that up. So you get to witness history today. October 15th through December 7th. The third bullet there is a special enrollment period. So people who have a cost plan that is going away December 31st of 2018 are being granted a special enrollment period. And you could almost think of it as an extension of open enrollment because the special enrollment starts December 8th and goes through February 28th. So it goes into 2019. People with a cost plan that is sunsetting are also going to have guaranteed issue rights into certain types of Medicare supplemental plans. Those guaranteed issue rights started November 2nd of 2018, and they go through March 4th of 2019. So that's an opportunity to enroll into certain types of Medigap plans without a health screening. And new to everyone on Medicare, but also important for people who have a cost plan that's going away, is the Medicare Advantage enrollment period. This is going to be a new enrollment period that is starting in 2019 and will be permanent and ongoing. It's going to start every year from January 1st through March 31st. And this is an opportunity for people on Medicare to make a one-time change to enroll into a new Medicare Advantage plan or to disenroll from a Medicare Advantage plan and return to original Medicare with a standalone Part D or perhaps try to enroll in a Medigap. I saw in the green Columbia first. Great question. So if you are already enrolled in a Medigap or Medicare supplemental plan, is there an annual open enrollment period for you? Correct? With Medigap plans, they can take new beneficiaries at their discretion, so they can require a health screening if we don't have a guaranteed issue rate period. So if we ever want to make a change to enroll into a Medigap plan or a new Medigap plan, we need to work with the insurance company on that. Wouldn't that be an incentive for them, disincentive for them to be competitive? perhaps it would be. And I always say this at some point during the presentation, and I'm going to say it now. Just remember that Brenna and I are the messengers. We don't make the rules. And I think there's a lot of opportunity. As Brenna articulated before, Medicare was created for acute care. It was never created to cover everything, and there's a lot of opportunities within this program. Oh, no, not to worry. I just like to say that at least one time, one because it gets a chuckle and kind of loosens people up. And I saw a hand in the back as well. Great question. So if I have a cost plan and I choose to enroll into a Medicare Advantage plan this year, next year during open enrollment or perhaps during the Medicare Advantage enrollment period, if I choose to enroll in a different Medicare Advantage plan, perhaps with a different company, can they do a health screening? No, Medicare Advantage does not do health screenings. Only Medigap, Medicare Supplemental Insurance, does the health screening. The one exception to that is end-stage renal disease. As it stands today, people living with end-stage renal disease or kidney failure cannot enroll into a Medicare Advantage plan. Medigap would be their option, so they'd really want to take advantage of a guaranteed issue right period. That will be changing in 2021, where people with end-stage renal will be able to enroll into a Medicare Advantage plan. Yes? Great question. So if I have a Medicare cost plan and I choose to enroll in a Medicare Advantage plan this year, perhaps using my special enrollment period, next year, so fall of 2019, can I enroll into a Medigap plan without a health screening? That answer is no. The guaranteed issue right period for people with a cost plan that is ending is limited to November 2nd through March 4th of 2019. Keep in mind, Medigap plans can take new enrollees at their discretion, so they could take new enrollees next year, but it's at their discretion. It's not a guarantee. Yes, I see. Great question. So once you're in a Medigap, do you have to qualify each year? As in, I'm thinking you're wondering about a health screening every year. Medigap plans do not do a health screening every year. No. Once you're into a Medigap, you are into the Medigap plan. The plan's premium can go up from year to year. And if you ever wanted to change to a different Medigap plan, you would need to work with the insurance company if you were outside a guaranteed issue right period, and would perhaps need to comply with a health screening at that time. But once you're in, you're in. Yes? So you currently have Blue Cross. Do they all? Does every insurance company have a Medigap plan? It varies. Different insurance companies will sell different products based on. And I have some great resources for Medigap plans that we'll talk about later on. And in the blue, you've been very patient. It is confusing. What is the difference between a Medigap and a Medicare Advantage plan? I'm going to get to a really helpful comparison in a couple slides, but just allow me to walk through these three different scenarios that I have for you first, and then we'll get to the key differences between Medigap and Medicare Advantage. Okay? All right, so you can think of it as there's 3 ways that for someone with a cost plan that is ending, their situation can play out. The first is that I'm a cost plan enrollee in an impacted county, so my cost plan is ending December 31st, and I have been deemed. So my insurance company has notified me that they have a comparable Medicare Advantage plan that CMS has approved of that I will be auto-enrolled into January 1st of 2019. So if I do nothing, I would be, in 2018, I would be auto-enrolled into that comparable Medicare Advantage plan to start January 1st of 2019. So one of my options is to be auto-enrolled. I also have an option to enroll into a different Medicare Advantage plan. Maybe I don't like the Medicare Advantage plan I've been deemed into, so I want to enroll into a different Medicare Advantage plan. I have, technically, October 15th of 2018 through March 31st of 2019 to enroll in a different Medicare Advantage plan. And that window of time combines Medicare open enrollment, the special enrollment period I have because my cost plan is ending, as well as the Medicare Advantage enrollment period. I could also choose to purchase a Medigap policy, and I could use my guaranteed issue rights between November 2nd of 2018 and March 4th of 2019. And I would also want to enroll in a standalone Part D plan for prescription drug coverage sometime between October 15th of 2018 and February 28th of 2019. Or I could return to original Medicare A and B without a Medigap, without Medicare Advantage, and have a standalone Part D plan. And in this situation, if we are choosing to be in a Medigap plan, or we want to return to original Medicare, we do want to be conscious and enroll in a standalone Part D for prescription drug coverage, because if we go 63 days without creditable Part D coverage when we are otherwise eligible for it, we could start to accrue a penalty. Yes?
I didn't know that if you're on an advantage plan, I mean, it varies from they cancel. But that's not the case if you're on a Medicare plan. So it seems like it would make sense to switch to Medicare now, where there's a guarantee issue situation. But you said that certain types of Medicare plans fit the Medicare enrollment window. I'm not sure what certain types those are. And if I apply for one, could they turn me down, not because of a health issue, but because I don't feel like it?
So there are a lot of parts to that question, so I'm going to try to break it down. So the first one of them was, if I have a guaranteed issue, my cost plan is ending, can they turn me down? They can't turn you down if you have a guaranteed issue. Has nothing to do with, it's not just about the health screening, it's that you have a guaranteed issue into that plan, so they can't turn you away for any reason. Another question was, I might need you to repeat them. Certain types, yeah. So the type of Medigap plan, and this is where it gets really confusing too. So the type of Medigap plan that we have guaranteed issue rights into, if our cost plan is ending, is a Medigap basic plan with certain riders. So Medigap plans are all standardized, and I'll talk about that in a moment, but it's a specific type of Medigap plan that we have guaranteed issue rights into. With that in mind, though, we have heard from insurance companies that some insurance companies are waiving the health screening for other types of Medigap plans. So it's not that we have a guaranteed issue into those plans, but the insurance company is choosing, because Medigap plans can choose, they can at their discretion take new enrollees. Some insurance companies are choosing to waive a health screening for Medigap plans beyond the Medigap basic. And that's something that Senior Linkage Line can help people navigate. We do not have guaranteed issue rights into an extended basic, so we would have a health screening for the extended basic unless that specific insurance company is waiving the health screening for people this year. Okay, so then the next scenario. I have a cost plan. I'm in an impacted county, and my cost plan is going away. I have a cost plan that includes Part D coverage, but I'm not being deemed. My insurance company has not come up with a comparable Medicare Advantage product for me to be auto-enrolled into. In this scenario, my cost plan and my Part D coverage will be ending December 31st of 2018. So my options are to enroll in a new Medicare Advantage plan between October 15th through March 31st of 2019 that again combines that window of time that is the Medicare open enrollment period, the special enrollment period for people with a cost plan that's ending, and the Medicare Advantage enrollment period. I can also purchase a Medigap policy, enroll into a Medigap Medicare supplemental plan between November 2nd and March 4th, or I could simply return to original Medicare A and B. This situation's a little tricky because my cost plan includes Part D coverage. So my Part D will be ending December 31st of 2018. So for this particular group, it is probably advantageous to make a change in 2018 so that the plan would be effective January 1st of 2019, especially when it comes to the Part D coverage, to ensure that we don't go without Part D prescription drug coverage. Because again, if we go 63 days without creditable Part D and we are otherwise eligible for it, then we could start incurring a penalty. Okay, and the third scenario, I have a cost plan. I'm in an impacted county. My cost plan is ending December 31st of 2018. I have not been deemed because I have a cost plan with standalone Part D coverage, so a separate Part D plan. So my cost plan will be ending December 31st of 2018. So if I do nothing in 2018, starting January 1st of 2019, I would have original Medicare A and B, and I would still have my Part D plan if I do nothing. My options are to enroll in a Medicare Advantage plan between October 15th of 2018 and March 31st of 2019. I could also purchase a Medigap policy between November 2nd of 2018 and March 4th of 2019. But keep in mind, technically my Part D plan is not ending. It's not tied in with my cost plan. So I do not get a special enrollment. I don't get to use the special enrollment period from December 8th through February 28th for changes for Part D. So any changes I want to make to a standalone Part D plan, I would need to make during open enrollment, December 15th or October 15th through December 7th. I know it's a bunch of numbers. I'm doing pretty good though, I think. Thank you. All right, and then my third option is to just return to original Medicare without a Medigap or a Medicare Advantage plan and have my standalone Part D coverage. But keep in mind, original Medicare does not have an out-of-pocket maximum. So if we're going to make that decision to be on original Medicare, just keep that in mind. There is not an out-of-pocket maximum for the year. So those are our three scenarios. Now I promised I would walk through the key differences between Medigap and Medicare Advantage. So we're going to go ahead and do that right now. Key differences. So Medigap plans have limited guarantee issue. So Medigap plans can take in new enrollees at their discretion and can require a health screening if we don't have guaranteed issue rights. We have guaranteed issue rights for the 6 months after we enroll in Medicare Part B initially. And if we have a cost plan that is ending this year, we also have guaranteed issue rights from November 2nd through March 4th of 2019. Medicare Advantage plans we can enroll into during Medicare open enrollment or during the Medicare Advantage annual enrollment period, unless we have end-stage renal disease, but that will be changing in 2021. Another difference is the standardization. So Medigap plans are all standardized. You've heard me mention a couple categories already, but a couple of the categories are Medigap Basic and Medigap Extended Basic. So the Medigap plans are standardized so the different categories of plans all have the same types of coverage. So if I'm looking at a Colonial Life plan, Colonial Life Medigap basic plan that costs $150 a month, and I'm looking at a Blue Cross Blue Shield Medigap basic plan that costs $170 a month, totally hypothetical. I don't even know if that's a real premium. Those plans have the same coverage. What will change is the premium cost and the customer service, but they have the same coverage. Medicare Advantage plans are snowflakes. They're all different. Medigap plans, I don't have a specific provider network. I can go to anyone who accepts Medicare. Whereas with Medicare Advantage, they do have a specific provider network that I need to operate through. That network can change. Some of the networks are pretty generous as well. Medigap plans, the policy provisions, what the plan covers doesn't change because Medigap plans are a true supplement to Medicare. They really only cover what Medicare covers. It's very rare that they go above and beyond. Whereas Medicare Advantage plans, they have annual contracts, so what they include for coverage can change from year to year. Medigap plans are portable, so if I live in Minnesota, I purchase a Medigap policy, and then I decide I'm going to move to Wyoming. When I make that move, I can keep my Medigap plan. Whereas if I have a Medicare Advantage plan that I purchase in Minnesota, and I move to Wyoming, if I'm now outside of that plan's network, I will have a special enrollment period when I change my address with Social Security to enroll in a different type of secondary insurance for the state of Wyoming where I now live. Medigap plans don't include prescription drug coverage. With Medigap plans, I always need to purchase prescription drug coverage separately. Medicare Advantage plans include prescription drug coverage. There's only one type of Medicare Advantage plans where I can purchase Part D separately, and that type is not currently sold in Minnesota. So with Medicare Advantage, I have to have prescription drug coverage with the Medicare Advantage. If I have a Medicare Advantage plan and I enroll in a standalone Part D plan, I will be disenrolled from my Medicare Advantage plan. Now, there are some Medicare Advantage plans that don't include Part D coverage. Why would that be? Especially if I have to have Part D included in my Medicare Advantage plan. Why would that be? Is anyone here a veteran? Couple veterans. So if you go to thank you for your service, first of all. But if you go to a lot of veterans go to the VA to get their prescriptions filled. So they don't really care about Part D. They don't want to pay for it. So that type of a Medicare Advantage plan might be quite appealing to them. All right, Medigap plans, yes. That is a great question. So I have a cost plan and standalone Part D. Can I enroll in a Medicare Advantage plan that doesn't include Part D coverage and keep my standalone? Unfortunately, the answer is no. Because with the Medicare Advantage plan, I have to have Part D coverage through the Medicare Advantage plan. They're combined. They're combined. There are some Medicare Advantage, if I have a standalone Part D, I would be disenrolled from my Medicare Advantage plan. The reason why some Medicare Advantage plans don't include Part D coverage is to cater to veterans, the veterans that go to the VA to get their prescriptions filled. Okay, and then Medigap plan, oh, I'm sorry.
Veterans only get free prescriptions if they have 70% disability.
Yep, so only some veterans get prescriptions, right? So that's something to consider as well. Okay, so Medigap plans are a true supplement for Medicare. So it's very rare that a Medigap plan will offer coverage for dental, vision, or a gym membership. Very, very rare. whereas Medicare Advantage plans will offer those or have the ability to offer those extra benefits. Yes? That is a great question. So the dental, vision, and hearing with the Medicare Advantage, is that an add-on that I have to sign up for right away at the beginning of the year, or is that something that I can purchase separately? So with the Medicare Advantage plans, typically those benefits are included, so they're already part of it. So when you sign up for the plan, but sometimes when you sign up for the plan, you sign up for those benefits. There is the option to also purchase those separately. That I am not clear on the rules. Mm-hmm. Yes. With both of those plans, can you go to Mayo? Medigap, you can go to anyone who accepts Medicare. So yes, as long as they accept Medicare, you can see them. Medicare Advantage plans, you want to check the provider network, but from what I have seen, many of the provider networks do include the Mayo system here in Minnesota. Medica does not, it sounds like. So it's something that's important to check because we all have different health situations and we all have different doctors that we want to see and we all have different comfort levels and needs. I only have 10 minutes left. So if you don't mind, I have 8 slides. So I'm going to just kind of click along. And Brenna and I will be around at the end if you do have any additional questions. Okay, so we already talked about this a bit, but the last piece here on this table is Medigap plans. We can enroll into a new Medigap plan at the plan's discretion if we're outside a guaranteed issue period. Medicare Advantage plans we can change annually. Okay, so there are some financial assistance programs that are available for people on Medicare that have a lower income and asset threshold. One of those programs is called Low Income Subsidy. That program is administered by the Social Security Administration, and it is intended to help with Medicare Part D premium costs, deductible costs, and coinsurance costs. The Medicare savings programs are administered by the county. These help with the Medicare Part B as in boy premium. There are 3 levels to this program based on the level of financial need, and they all have slightly different benefit structures. This Healthcare Choices book that I brought for you today, and there's also a slide on it that I will get to, this book does have the eligibility guidelines for these programs listed in it. Senior Linkage Line can help people determine whether they qualify for these programs. They can also help with directing to the right application. Metropolitan Area Agency on Aging is actually who I work for. You heard me say that at the beginning. I work for Metropolitan Area Agency on Aging on the Senior Linkage Line team. Many people aren't familiar with the area agencies on aging, but there are actually 7 of us here in Minnesota. 6 of us partner with the Minnesota Board on Aging to deliver the Senior Linkage Line service. The Senior Linkage Line is statewide information, assistance, and referral for older adults, people on Medicare, and people who care about them. We are free to call. We're open Monday through Friday, 8 to 4:30. We do have interpreter services available, and we are able to make up to a 5-way phone call. Well, what does that mean? A lot of us are making these decisions not by ourselves. We want to have other people on the line to hear, or maybe ask some questions. So we are able to include multiple people on a phone call. I once had a phone call where it was me, the Medicare beneficiary, his adult daughter, an interpreter, and the Part D plan trying to resolve a prescription access issue. We didn't have very good quality, but we got the job done. So we are able to have up to a 5-way phone call. I mentioned this before, but we are the Designated State Health Insurance Assistance Program, otherwise known as SHIP, for the state of Minnesota. So we are the go-to for objective questions and answers about Medicare. The goal of Senior Linkage Line is to keep people independent by connecting them to home and community-based resources. We are objective in our referrals. That might be frustrating for some people. A lot of people will call us and say, well, who should I use or what should I do? And we can't tell you what to do, and we can't tell you who to use. It's our job to listen to our callers, ask clarifying questions, and then provide suggestions for resources that could be helpful, and provide guidance for system navigation, and empower the caller to make the decision about what's best for them or their loved one. We're best known for our health insurance counseling. It is about 50% of our calls. Our health insurance counseling is available to anyone on Medicare of any age. Our counseling is available over the phone at our 1-800-333-2433 number. We also have about 50 sites where we meet with people in the community here in the 7-county metro. At this time, those sites are all full, so we are encouraging people during this open enrollment period to just go ahead and call it into our call center. As Sarah mentioned before, we're not salespeople. Senior Linkage Line is not brokers. We receive no type of compensation from the insurance company that we help people enroll into. Our true passion and goal is to help people identify the correct plan, the correct Medicare situation to fit their needs. I was at a presentation and a woman told me that her son had spent hours researching the perfect Medicare secondary insurance to fit her needs. Hours, and he found a specific plan where he said, Mom, this is the plan you should get. And then this woman called the Senior Linkage Line and spoke to one of our specialists. And our specialist came up with the exact same plan to meet this woman's needs. And I looked at that woman and I said, I bet that gave you a lot of peace of mind that you were making the right choice. And she said, you bet it did. You bet. So sometimes we're just one piece of this decision because maybe we have a trusted broker we want to utilize, or a family member or a friend. But just keep in mind that we are available as a free resource to you. I mentioned healthcare choices already. You can see the website on the screen. mnhealthcarechoices.com is where this book can be found digitally. I did bring 100 copies for you today, and I would love to take none home with me. So please feel free to grab a copy. Sometimes this book is edited throughout the year. As we know, things with Medicare changes, so we work hard to keep the book edited. We typically don't print more paper copies, but the Board on Aging does edit the online version, so we do encourage people to reference the online version. This book is a great place to look to compare Medigap plans and Medicare Advantage plans and Part D plans. It's a true apples to apples comparison. Another great resource that we've already talked about is Medicare.gov. This is the official government website for Medicare. This website has a phenomenal tool called the Plan Finder tool. You see those 3 green buttons kind of in the middle of the screen? There's one button with a little magnifying glass that says Find Health and Drug Plans. I would invite you to circle that button on your slide. That button will take you to the Medicare Plan Finder tool. With the Plan Finder tool, we can put in our Medicare information, and this is a secure site, so it's safe to do that. Our Medicare information, our prescriptions, our pharmacy, where we live, and the tool will generate for us a list of Part D and Medicare Advantage plans and whether they cover our prescriptions, how they cover our prescriptions, when we might hit the donut hole, what our monthly costs could be, etc. If we're not comfortable using this website, Senior Linkage Line specialists use this website, so you're welcome to call us for health insurance counseling, and we can help with this plan comparison tool. And then some other resources for assistance: Metropolitan Area Agency on Aging. Our website, metroaging.org, does have a list of other Medicare presentations we are doing out in the community with regards to these changes. So I would invite you to encourage loved ones to look at that website. It also has our health insurance counseling sites listed on there. I did mention that those are full at this time, but if you are looking for a one-on-one face-to-face appointment, perhaps in 2019, those can be found, the locations can be found on our website. There's also the Senior Linkage Line phone number. I brought a whole bunch of Senior Linkage Line magnets with me today. They're at our front table, and our phone number is the 1-800-333-2433. There's the Minnesota Board on Aging website, which also has great information about changes with Medicare, and the Center for Medicare and Medicaid itself. It is exactly 3 o'clock. I did quite well. Thank you for letting me work through those. Brenna and I will be around if you have questions. Thank you for your time.